Today we are speaking about the anatomy of the extraocular muscles. What about the extraocular muscles? You have to know what are the muscles, what are their origin, the insertion, the nerve supply, and their action. The extraocular muscles, that are the muscles moving the globe, there are 6 muscles, but in addition we have to know that there is another muscle included, but this muscle is moving only the upper eyelid. This is the Levator Palpebrae Superioris, and this muscle you will know all its detail when studying the anatomy of the upper eyelid. The extraocular muscles moving the globe, there are known 6 muscles, 4 recti and 2 oblique muscles. The 4 recti, as we see here from the picture, the superior rectus, number 1, which is above the globe, the inferior rectus below the globe, the medial rectus to the medial side, the lateral rectus on the lateral side, then the superior oblique and the inferior oblique. All these muscles to know are supplied by the oculomotor nerve except 2 muscles. The lateral rectus, which is supplied by the 6th nerve or the abducens nerve, and the superior oblique is supplied by the 4th cranial nerve. This is the Levator Palpebrae Superioris, the cut section. It is in the cut section, it is known to be here above the superior rectus. Here is the superior rectus, here is the Levator Palpebrae Superioris. The origin of the extraocular muscles, as we said, all extraocular muscles arise from the apex of the orbit except one muscle. This muscle is the inferior oblique muscle, which is arising from the anterior part of the floor of the orbit here. All others arise from the apex of the orbit surrounding the optic nerve. Here is another photo to show. Here is the optic nerve in the optic foramen, and superior rectus above, inferior rectus below, then medial rectus, lateral rectus, and here is the superior oblique. Here is the origin of Levator Palpebrae Superioris above the superior rectus. All these muscles forming the cone of muscles surrounding the optic nerve and the intraconal compartment inside. The only muscle arising away from them is the inferior oblique, arising from the floor of the orbit in a rough impression just lateral to the opening of the nasolacrimal bony canal. This is another picture to show us the origin of the extraocular muscles around the optic nerve and forming the cone of muscle. Superior rectus, inferior rectus down, medial rectus medially, lateral rectus laterally, and we have the superior oblique between the superior rectus and the medial rectus, and the Levator Palpebrae Superioris origin is above the superior rectus origin. And we have to know the structures passing through the superior orbital fissure. We study all of them in the anatomy of the orbit. Again, this is the cone of muscle, another photo, to show that all the muscles except the inferior oblique arise from the common tendinous ring in the apex of the orbit. This is called the annulus of Zinn. They are connected together, all these muscles, by intermuscular septa to protect the intraconal compartment where important structures are passing. The most important is the optic nerve with the vessels and nerves surrounding. Now we'll speak about the insertion, the second item. You know what are the muscle, what are their origin, all of them apex of the orbit except the inferior oblique muscle. Now the insertion. all muscle, 4 muscle recti, the 4 recti muscle, superior rectus, major rectus, inferior and lateral recti, are inserted in front of the equator, while the superior oblique and the inferior oblique are inserted behind the equator in the posterolateral quadrant. The insertion is having a special pattern. The major rectus is inserted away from the limbus by 5.5 millimeter. The inferior rectus 6.5 millimeter from the limbus. The lateral rectus 6.9 and the superior rectus 7.7 millimeter. This is forming a spiral line called the line or spiral of Chilo. The oblique muscles insertion are inserted behind the equator. As we see from this photo, the part of the superior oblique muscle, reflected part from the trochlea till the insertion, is parallel to the inferior oblique muscle from origin to insertion. But one is above the globe and one is below the globe. This one inserted in the posterolateral quadrant and the inferior oblique also in the posterolateral quadrant. So again, the recti muscle, I want you to know all these details by the end of the lecture, even before studying. The recti muscles are inserted in front of the equator, forming the line of Chilo, 5.5 for the major rectus, 6.5 inferior rectus, 6.9 for the lateral rectus, and the superior rectus is 7.7 millimeter away from the limbus, forming the spiral of Chilo again, and the oblique muscles inserted behind the equator. Now, the innervation. The innervation of the extraocular muscle. As a rule, all of the extraocular muscle, and again with the Levator Palpebrae superioris, are supplied by the oculomotor or the third cranial nerve, except 2 muscles. The lateral rectus supplied by the abducens or the 6th cranial nerve, and the superior oblique supplied by the trochlear nerve or the 4th cranial nerve. All others supplied by the oculomotor. The oculomotor or 3rd cranial nerve is divided into 2 divisions. The superior division supplies 2 muscles, Levator Palpebrae superioris and superior rectus. The inferior division supplies all the remaining major rectus, inferior rectus, and inferior oblique muscles. And also we are having something special, the parasympathetic fibers that are going with the oculomotor nerve from the start of its origin in the midbrain. The oculomotor is arising from the midbrain at the level of superior colliculus, and it is having the parasympathetic fibers going with it till the nerve, the inferior division, and then to nerve to inferior oblique. So this is the oculomotor superior division supplying Levator Palpebrae superioris and the superior rectus. The inferior division with the parasympathetic fibers going with it is supplying major rectus, inferior rectus, and inferior oblique. The parasympathetic fibers are coursing with this nerve to inferior oblique, leaving it to relay in the ciliary ganglion to give postganglionic parasympathetic fibers entering the orbit to supply 2 important structures, the sphincter pupillae and the ciliary muscle of accommodation. So, if there is paralysis of the oculomotor nerve, it could be either external ophthalmoplegia that is affecting only the extraocular muscles, sparing the pupil and the accommodation, or it can be total ophthalmoplegia affecting also the sphincter pupillae and the ciliary muscle of accommodation, and in this case it is internal ophthalmoplegia in addition to external ophthalmoplegia, that is total ophthalmoplegia of the 3rd nerve, and we will see that in photos. The action of the extraocular muscles. The function of the extraocular muscle is directed, or it is monitored around three axes: around the horizontal axis, a vertical axis, and an anteroposterior axis. Movement around the horizontal axis causes elevation or depression. Movement around a vertical axis causes the eye to come inside or outside, that is, to causes adduction or abduction. While movement around an anteroposterior axis makes the globe to turn in torsion, or extorsion, to turn out. All the 6 extraocular muscles act in union to move the globe. When one muscle contracts, the opposing muscle relaxes, creating smooth movement. In addition to the muscles of one eye working together in a coordinated effort, the muscles of both eyes work in union to keep both eyes aligned and parallel to each other. So, we can take it in details. The action of the recti muscle. The medial rectus causes adduction only. The lateral rectus, abduction only. They are moving around the vertical axis. No torsion caused by this muscle. Only one action: adduction for the medial rectus and abduction for the lateral rectus. So these two extraocular muscles create no torsion on the eyeball. The medial rectus is a pure adductor, lateral rectus is pure abductor. I think this is clear. The remaining muscles, the superior and inferior recti and the superior and inferior oblique, do cause torsion of the eyeball. Collectively, these 4 muscles are termed the cyclovertical muscles because each of them is causing torsion as well as elevation or depression. To look for the superior and inferior recti, there is an important structure here that the muscle, the axis of the muscle, whether the superior rectus above the globe or the inferior rectus below the globe, is forming an angle of 23 degrees with the visual axis of the eye. So, if the eye is turned out by this 23 degree, both will be in the same line. That is, the axis of the globe will be at the same line or coincide with the axis of the muscle, and here the levator, the superior rectus will act as an elevator and the inferior rectus will act as a depressor in abduction. While if the globe is turned inside by 67 degrees, so that the globe will be perpendicular to the axis of the muscle, the superior rectus will no more do elevation and depression, and it will do intorsion for the superior rectus and extorsion for the inferior rectus. We'll see this again in another slide. So the vertical recti action, when the globe is abducted to 23 degrees, the visual axis will coincide with the line of pull of the muscle, and the superior rectus will act as an elevator, inferior rectus acts as depressor. When the globe is abducted to 67 degrees, the visual axis will be perpendicular to the line of pull of the muscle, as we saw in the photo, and in this case the superior rectus causes intorsion and the inferior rectus causes extorsion. Again, we look to the muscle to see that the obliques are completely different. We consider the superior oblique, the active part, as the part coming from the trochlea here and reflected back to be inserted into the posterolateral quadrant of the sclera, and the inferior oblique as the part parallel to this portion originating from the floor of the orbit and inserted into posterolateral quadrant of the sclera. These two parallel parts or two parallel muscles of the oblique are having these directions. The superior oblique and the inferior oblique below the globe are forming 51° with the axis of the globe or the visual axis of the globe. So if the globe is turned inside, adducted to the 51°, the axis of the globe and the axis of the muscle will be coinciding to each other. And in this case, the superior oblique will act as a depressor of the eye in adduction, and the inferior oblique will act as an elevator of the eye in adduction. Why causes depression while the muscle is above the globe? Because of the insertion is behind. When we pull the insertion toward the origin, the superior oblique will act as a depressor, inferior oblique as an elevator in adduction. While if the globe is turned out 39° to be perpendicular to the axis of the muscle, in this case, no elevation or depression, and the other movements will occur. Superior oblique causes intorsion, inferior oblique will cause extorsion. Here is another photo, the same superior oblique, inferior oblique, the axis of the visual axis and the axis of the muscle are forming together 51°. If the muscle is coinciding with the visual axis by adduction of the globe, there will be depression by the superior oblique in adduction, elevation in adduction by the inferior oblique. So again, to repeat or to summarize, when the globe is adducted to 51°, the visual axis coincides with the line of pull of the muscle, and the superior oblique in this case will act as a depressor, while the inferior oblique acts as an elevator. When the globe is adducted to 39, the visual axis in this case is perpendicular to the line of pull of the muscle. The superior oblique causes intorsion, and the inferior oblique will cause extorsion. There is an important rule. This is again to summarize and see the obliques and the recti. These are in front of the equator, and the obliques are behind the equator. To summarize the action, medial rectus is causing only adduction, lateral rectus only abduction around the vertical axis. The superior rectus causes elevation in abduction and intorsion. This is the secondary action. The inferior rectus, depression of the eye in abduction and extorsion, the secondary action. Superior oblique, the primary action, when because it is nearer to the visual axis by the 39°, causes intorsion and inferior oblique extorsion, and the secondary action is the depression and elevation by superior oblique and inferior oblique. I want to tell you something. The muscles above the globe, as superior rectus and superior oblique colored in red, are causing intorsion of the globe, while the muscles below the globe have an extorsion movement. So to test the extraocular muscles, we are testing either the monocular movement, that is movement of one eye alone by covering the other eye, or we can test the binocular movement, which are the movement of both eyes together, either in the same direction called the version movement, or the vergence movement of the two eyes in opposite directions as the convergence or the divergence. Deduction movement or the monocular movement, we test the medial rectus. Medial rectus is causing adduction, looks medially. Lateral rectus causing abduction, or tested by testing abduction by looking laterally. Superior rectus up and out. Inferior rectus down and out. superior oblique, down and in, inferior oblique, up and in. Version movement, movement of the two eyes together. This is important to compare if there is some paresis in one muscle or some overaction. This we will see exactly when we go to the lecture of paralytic squint. Version movement, we can detect if there is some paresis or some overaction in one of the muscles. Looking right, we are testing the right lateral rectus and left medial rectus. Looking to the left, we are testing the left lateral rectus and right medial rectus. Looking up and to the right, we are testing the superior rectus of the right eye and the inferior oblique of the left eye. Looking up and to the left, we are testing the superior rectus of the left eye in abduction and the inferior oblique of the right eye. Looking down and to the right, this action is done by the right inferior rectus and left superior oblique, while down and to the left, left inferior rectus and right superior oblique. Here is to show that up and to the right, right superior rectus and left inferior oblique. And for example, down and to the left, left inferior rectus and right superior oblique. What are the synergistic movements? Synergistic movement means that increased innervation of a muscle is accompanied always by an increased innervation of the contralateral synergistic muscle that is called the yoke muscle of the other eye. And this is important also in when we will study the paralytic squint, to know that there is a law of equal innervation, Herring law of equal innervation. Equal innervation going to the lateral rectus of this eye and medial rectus of the other eye. Also equal innervation going to the lateral rectus of this eye and medial rectus to the other eye. What are the antagonistic movement? Medial rectus of one eye is accompanied by inhibition of the lateral rectus of the same eye. Here is an example of sixth nerve palsy. The eyes seem parallel, but here when looking to the right, the eyes are parallel, but when looking to the left, there is defective adduction. This is well detected when we are testing the movement of the two eyes together, the version movement. Here also there is abduction deficit of the left eye. When looking to the right, both eyes are parallel, and here when looking to the left eye couldn't abduct. This will be seen again in paralytic squint. Don't be in a hurry. Here, fourth cranial nerve dysfunction. The superior oblique, when it is paralyzed, cannot depress the eye in adduction. So its antagonist, the inferior oblique, is the only muscle acting in this direction and causing elevation of the eye in adduction alone, without being opposed by the superior oblique, which is not functioning. Here, bilateral inferior oblique overaction. In this case, it might be primary inferior oblique overaction or secondary to superior oblique palsy. We will know this after studying also paralytic squint. Oculomotor nerve palsy, complete ptosis due to paralysis of levator palpebrae superioris, and when we elevate the lid, we see that the globe is abducted and slightly depressed. Abducted because the lateral rectus is acting, and slightly depressed because superior oblique is acting. Thank you, and hoping that everything was clear. Thank you so much.